Patient selection for a duodenal ulcer perforation closure is done carefully. It's preferably young adults with ASA 1 2 who have an early presentation less than 48 hours, who are hemodynamically stable with no organ dysfunction should be selected. Patients who have severe ILEs should be excluded as it makes the procedure technically difficult. Patients with a Bowie score, peritonitis score of 0 and 1 are the ideal patients for this. The port placement is depicted here. The camera port is at the level of the umbilicus. The right and left hand working ports are also at the level of the umbilicus at the midclavicular line. This allows access to all four quadrants. And an additional flow port is placed in the right flank at the level of the anterior axial line. At some point in the procedure, basically we need that to use that port for the subhepatic drain placement at the end of the perforation closure. The procedure starts with draining the pus and the fibrin flakes in all quadrants of the abdomen. Basically, we select patients with early peritonitis, so most of the pus is quite thin and the fibrin flakes are also easily removed by suction. We systematically go in all quadrants, the subhepatic and the right subphrenic region. That's the perforation there. You can see that the right paracolic gutter, pelvis, the left paracolic gutter, the left subhepatic region and the left subphrenic region. That's the pus in the left subphrenic region. Once that is done, we start again doing the lavage in all quadrants in the same fashion. A thorough lavage is done and all the fibrin flakes are cleared. Again in the same order, like the perihepatic and the subhepatic region, a thorough lavage till all the pus and all the flakes are cleared. Go on to the paracolic gutters and the pelvis. That's the left subphrenic area. That's one area where a bit of extra time has to be spent. Even perisplenic. Also, the pus and flakes are cleared in a thorough lavage. That's the left subhepatic region. These are all sites of potential residual abscesses if we don't spend our time. As important as the closure is this part. Like you can see, there's a lot of pus flakes, perisplenic. So all these should be every part of the abdomen should be meticulously cleared and a thorough lavage given. If there are thick flakes, we can put them in one area like the pelvis or in the subhepatic region and then suck them out, or we can place them in a bag. So that's the left subphrenic area being completely cleared of all the flakes and pus. Likewise the pelvis. We next turn our attention to an important part of the procedure, especially in laparoscopy, the part that is missed, that is the drainage of the interloop abscesses. So for this we need a bit of patience. The colon and the omentum are being taken up, and from the IC till the DJ, we do a bowel walk, and you can see there's all the interloop abscesses there, which are drained and sucked out. So this is one aspect which is a disadvantage in laparoscopy, that if you don't pay attention to the interloop collections, they can form interloop abscesses later on in the post-op period, and these are even difficult to drain by a PCD or something because there's bowel loops all around them. The flakes, you can see, if there are any thicker flakes, you just go put them in a bag, or in this case we're just placing them in the pelvis so that we can suck them out later. This way a lot of time is spent in the lavage and a thorough bowel walk to sort of clear out all the interloop collections and drain it. This is a very important step in any laparoscopic surgery for peritonitis, which is actually a common disadvantage. If people don't do a thorough job in this, you could be left over with residual interloop abscesses. So once all this is done, all the bowel walk is done and all the interloop abscesses collections are all drained, we complete the procedure with one more last lavage, suck out all the flakes we put in the pelvis, and we are ready to give one more lavage before we do the closure. One thing is, before we do the omental patch and all that, we want to finish all our lavage thoroughly, because when you're doing those manipulations, you don't want your instruments getting disturbing the omentum and tearing it, because it's all very friable tissue. So once we complete all the again, once after the interloop abscesses are drained, we do the lavage once again. After everything is thoroughly done, we are satisfied with our peritoneal toileting, only then we go to the omental patch closure. We now identifying the omental patch for the closure. So it's very early peritonitis. You might have a very thin omentum which you can directly take, but in this case you see the omentum, it's about a 48-hour-old perforation, so omentum is a bit caked up. So we would need to mobilize the omentum so that a patch reaches there very easily. The omental flap reaches there very easily to do a comfortable patch. Obviously, the other options are you can use the falciform, and a glue plug is also described, but we have no experience with it. But most of the time, I mean, you always have the omentum there for the patch closure, or rarely you can use the falciform. So this is the omental patch that's been mobilized. You can see that it's freely lying over that, and then we start the closure. So basically, take 3 stitches pre-placed. This is the first stitch being taken. This is a 20 silk we use. So basically we want to use different threads for the one for the central stitch. This is the central stitch. We're going to place one proximal and distal. For that we're going to use vicryl. So basically use different sutures so that once we have pre-placed, we don't have any confusion as to the ends when we are tying. So when we are taking the stitches, the only concern is just make sure that you're not taking the posterior wall. And that is the distal stitch, again with vicryl. So above, below, we can use the vicryl and central silk, or the reverse. Basically what this does is, once we place the patch, we don't have much of confusion digging around. So the important simplification of this technique is that basically in the first stitch, the distal stitch, when we are tying it, as you see, we've taken the omentum also in the stitch. What this does is, it fixes the omentum in the place, so that we don't have to worry about the omentum moving here and there when we sort of close the other stitches. So the first stitch, by taking the omentum with it, it sort of stabilizes the omentum and keeps it in place for the rest of the sutures. The 2 sutures, the principles are exactly the same as we do in open surgery. This is a modified Graham's patch closer. We don't close the perforation. We just put a omental plug patch over it. The sutures are tied, not too tight to sort of infarct the omentum, but reasonably snug. And that's the center stitch being tied. So it's basically an exact replication of how we handle the duodenal perforation in the open technique. Now this is the proximal stitch being tied. If we feel it's a bit loose, we can snug it using a clip, as you've seen there. So that's the completed perforation closure. Like I said, all the lavage and the toileting is completed before we do, so that we don't disturb the patch. An extra port is placed in the right flank anteraxillary line, as you see here, and a plane is placed in the subhepatic region, and another drain is placed deep into the pelvis to complete the procedure. The post-operative recovery was uneventful. Thank you.